You've been told fiber is essential for good health, but what if I told you on a ketogenic or a carnivore diet you don't need any at all? Let's uncover the science what they never told you about. Okay, this is going to be one of our myth busting new series, The Truth About Fiber Requirements, Why Keto Changes Everything. So let's get into it. Fiber requirements depend on your metabolism. Nutrition science has a dirty secret about fiber. The recommendations everyone follows aren't based on preventing deficiency diseases. They're based on population associations and stool bulk. Yes, the distinction matters more than most people realize. Fiber receives an adequate intake classification rather than being designated as an essential nutrient because inadequate intakes do not result in biochemical or clinical symptoms of a deficiency. Essential nutrients like vitamin C have clearly defined deficiency diseases. Miss vitamin C long enough, you get scurvy. Miss essential amino acids, your body breaks down muscle tissues to compensate. Miss fiber, your stool gets smaller. Okay? The science behind nutrient classification. The Institute of Medicine establishes fiber's adequate intake, contingent on the amount of kilocalories consumed, rather than setting requirements based on preventing deficiency symptoms. This represents a fundamental departure from how truly essential nutrients are determined. Vitamin C gets a recommended daily allowance because researchers can measure plasma levels, define scurvy, and establish body pools. Essential amino acids receive similar treatment because the body cannot synthesize adequate amounts independently. Fiber gets different treatment entirely. No blood test measures fiber status. No deficiency syndrome emerges when intake drops to zero. The daily recommended amounts were originally derived from observational data that reflected a lowered risk of coronary heart disease in populations that consumed an adequate amount. Population studies, not physiological requirements, drive these recommendations. This creates a critical problem when applying population-based guidelines to individuals following a ketogenic or carnivore dietary approach. So why do population studies miss the metabolic context? Well, most fiber research comes from high carbohydrate populations using food frequency questionnaires. In these contexts, fiber often serves as a proxy for better overall carbohydrate patterns. Higher fiber intake typically means more whole grains displacing refined starches. The apparent protective effects may reflect what fiber replaces rather than fiber itself. The substitution bias becomes problematic when extrapolating findings to ketogenic metabolisms. Someone in sustained nutritional ketosis already has an optimized glycemic load, optimized insulin sensitivity, and optimized inflammatory markers. The baseline metabolic context differs dramatically. Triglycerides drop, HDL rises, C-reactive protein decreases, and glucose variability stabilizes, right? The absolute room for additional risk reductions through fiber supplementations becomes much smaller, if non-existent. Food frequency questionnaires compound this problem with substantial measurement error. High fiber intake correlates with dozens of other healthy behaviors that inflate fiber's apparent independent effects. You also have cellular adaptation replaces dietary dependence. Most fascinating aspect of fiber elimination involves what happens at the cellular level in the colon. Colonocytes don't simply lose their primary fuel source and deteriorate. They adapt. Colonic epithelial cells, that's the skin cells on the inside of your colon, express monocarboxylate transporters, especially MCT1, on their membranes. These transporters carry both short-chain fatty acids and ketone bodies like beta-hydroxybutyrate. In nutritional ketosis, circulating beta-hydroxybutyrate rises to millimolar concentrations. It gets high enough to be fully measured. This creates a gradient allowing colonocytes to import and oxidize ketones for ATP production, even when luminal butyrate from fiber fermentation drops to zero, right? And if you read anyone who says you need fibers because they're looking for the fermentation of short chain fatty acids, right? And you don't need that if you have beta hydroxybutyrate. The colon epithelium also expresses HMG-CSH2, the rate-limiting enzyme for ketogenesis. Ketogenic states upregulate this metabolic program, supporting epithelial differentiation and barrier function independently of dietary fiber. Right? You don't need dietary fiber to ferment in your gut, which is not a natural state for human beings, if you have beta-hydroxybutyrate, ketone bodies. Beyond fuel substitution, ketones provide signaling benefits traditionally attributed to butyrate. Beta-hydroxybutyrate, you notice that the two seem very similar in name, right? Functions as a historical decolylase inhibitor, supporting antioxidant defenses and healthy gene expression patterns in epithelial cells. Once again, skin cells on the inside of your colon. This epigenetic signaling helps maintain tight junction integrity and suppresses inflammatory pathways like NLRP3 inflammasome activation. It actually helps keep your colon nice and tight, and healthy, which is the whole reason they tell you to eat fiber. Doesn't apply. All right. Clinical evidence challenges fiber necessity. Multiple randomized controlled trials have tested whether increasing fiber intake prevents colorectal problems. The results consistently disappoint fiber advocates. So there was a Cochrane review, which is considered the gold standard of the multi-study reviews, right? They showed no evidence from RCTs to suggest that increased dietary fiber intake will reduce the incidence or recurrence of polyps within a 2 to 4 year period. It doesn't do anything. Large studies like the polyp prevention trial assigned over 2,000 adults with prior issues to high fiber diets versus usual intake for 4 years. No reduction in recurrence or advanced polyps emerged. Parallel trials testing wheat bran fiber supplementation showed similar null results. Some trials even found higher recurrence rates in fiber supplemented groups. Yeah, this happens a lot, right? You take fiber, and your body's it's reactive to these in a negative fashion. Okay, these findings create cognitive dissonance with observational studies suggesting protective effects. The disconnect likely reflects the difference between controlled interventions and population-level dietary patterns. Right? Clinical experience with exclusive internal enteral nutrition provides another data point. These fiber-free formulas routinely induce remission and mucosal healing in inflammatory bowel conditions, right? Demonstrating that epithelial repair doesn't require dietary fiber. So let's recognize what normal adaptation is versus dysfunction. Transitioning from a high fiber to a very low fiber intake triggers predictable physiological changes. Understanding normal adaptation prevents unnecessary intervention. The first 2 to 4 weeks typically involve stool pattern shifts. Some people get mild cramping, some get transient digestive changes. These symptoms usually resolve once electrolyte balance and fat to protein ratios optimize. Okay? Which is one of the reasons when we talk about it, most people we do suggest a 2 to 4 week period, maybe as much as 6 weeks, in terms of reducing your plant intake until you get to zero plants and are fully ketogenic and fully carnivore. Okay? Ketosis induction causes well-documented sodium and potassium losses. Most early gastrointestinal complaints improved with deliberate electrolyte repletion rather than fiber supplementation. Yeah, and you hear a lot about this in the carnivore community, right? Taking your salts and your magnesium and stuff when you hydrate. Red flags require medical evaluation, including nocturnal diarrhea, blood and stool, fever, unintended weight loss, or severe abdominal pain. So if this is happening, something's wrong in your gut, so we need to look at that before you start changing too much in terms of your diet. These symptoms suggest organic disease rather than dietary adaptation, right? Bile acid diarrhea represents a common and correctable mechanism when dramatically increasing fat intake. Yeah, if you switch it overnight and you are now eating 80% of all of your nutrition is fat, and you never had that much fat in your life, your body's not going to react properly to that. It takes time to switch over to this. Okay, so um, high fat meals spike cholecytokinin, triggering gallbladder contractions, which is where you're getting the pain from, that flood the small intestine with bile acids. Give your body a chance to get used to eating high fat uh, carnivore. Okay, if bile acid reabsorption gets overwhelmed, excess acids reach the colon, stimulate water secretion, right? I.e., you get some diarrhea, and this creates watery, urgent diarrhea that responds to gradual fat titration or small amounts of viscous fiber that bind bile acids, right? Um, that's eating too much fat at once. Get used to eating fat, okay? The key insight: bile acid diarrhea reflects a feedback adaptation problem, not a fiber deficiency, okay? So once again, if you're eating a very high fiber, very plant oriented diet right now, and you want some of the benefits of going to a ketogenic carnivore diet, give your body time to get used to the changes you're going to send down into your intestines and your colon. Okay, give it a chance to adapt to that. That's all I can say, right? And I say that a lot. So there are some biomarker guided personalizations you might want to look into. The future of nutrition moves beyond universal recommendations toward individualized protocols based on metabolic phenotyping. Fiber requirements exemplify this personalized approach. Continuous glucose monitoring reveals whether someone needs fiber for glycemic control. If glucose remains stable in ketosis, fiber adds no metabolic benefit for blood sugar management, right? Which is one of the first things that happens when you switch to a ketogenic carnivore type diet. Your blood glucose within a couple of weeks tends to fall in place. Insulin resistance markers like fasting insulin and triglyceride to HDL levels indicate metabolic context. High triglyceride to HDL ratios suggest greater potential benefit from carbohydrate restriction than fiber supplementation, right? You have insulin resistance. You don't help your body get rid of insulin resistance by eating fiber. You do it by eating proteins and fat. Fecal calprotection screens for intestinal inflammation. Elevated levels indicate active inflammatory processes that require medical evaluation rather than dietary fiber, right? If you're having gut dysbiosis, maybe there's an organic reason for it. Maybe you do have some sort of a bacterial or a viral infection or something else going on. If this is becoming a problem, this is something to check into. Bile acid handling can be assessed through serum C4 and FGF19 measurements. Elevated C4 suggests hepatic bile acid overproduction, while low FGF19 indicates impaired allele feedback. These biomarkers identify candidates for bile acid sequestration therapy, something you should be working with your doctor with. Okay, so once again, something to keep in mind if you're having what you think are bile problems, right? And that's the diarrhea, you got fat floating in your stool, stuff like that. Maybe you're just not digesting the fat. Have your doctor help you look into that. Breath testing for methane identifies slow transit phenotypes where large fiber loads often backfire, right? Methane positive individuals typically benefit from low FODMAP, viscous fibers in microdoses rather than bulk forming supplements, right? So a whole bunch of us, it's just fiber is just bad for you, okay? Not everyone, but a whole bunch. Bristol stool form and symptom scores provide practical outcome measures for N of 1 trials, comparing no fiber versus microdose fiber interventions. Okay? And that becomes the thing. Microdose fiber. If you're eating a ketogenic or a carnivore diet, there is a call sometimes for what we call microdose fiber, taking specific types of fibers for specific effects for a short period of time. Okay? It doesn't hurt. Okay, practical implementation strategies. Implementing a personalized fiber approach requires systematic methodology rather than dogmatic elimination or inclusion. Start with metabolic optimization through carbohydrate restriction and electrolyte management. Many perceived fiber needs resolve when insulin, inflammation, and mineral balance improve. If loose stools develop during fat adaptation, address bile acid overflow through gradual fat titration and MCT oil substitution. MCT's oil via the portal circulation without requiring bile acid dependent Micelle formation. Consider therapeutic microdoses of viscous fiber only for specific indications like bile acid diarrhea or targeted LDL reduction. 1 or 2 teaspoons of psyllium husk provides bile acid binding without meaningful carbohydrate load. But only do this if you're making too much bile acid. Your body's not used to the amount of bile acid you're producing. Because, once again, you want the bile acid to break down the fat that you will be consuming on a carbohydrate or ketogenic diet. Monitoring ketone levels to ensure any fiber intervention maintains metabolic benefits. Right? Don't take fiber and watch your ketone levels drop. That's not good. Beta hydroxybutyrate should remain in the 0.5 to 3 millimole a liter range for nutritional ketosis. You want to be in that nutritional ketosis range. Track symptoms systematically using validated tools like the IBS symptom survey score rather than relying on subjective impressions. Okay? And I can help you get that if you need it. Addressing social and family concerns. Adopting a personalized fiber approach often triggers concern from family members and healthcare providers accustomed to universal recommendations. Effective communication focuses on scientific classification and individual response rather than dietary philosophy. Explaining that fiber receives an adequate intake rather than a recommended dietary allowance helps contextualize the flexibility in requirements. Emphasizing proven prevention strategies like colorectal cancer screening provides reassurance about health priorities. Screening has clear mortality benefits, while fiber supplementation trials show no results for adenoma prevention. That's colon cancers. Okay? Sharing objective health metrics like glucose variability, lipid panels, and inflammatory markers demonstrate that metabolic health can improve without meeting conventional fiber targets. In fact, it improves probably better. We'll see, Offering compromised positions like symptom-targeted microdosing shows flexibility while maintaining metabolic benefits. Okay, your doctor's stuck sometimes in what they're used to, and you have to work with them on this sort of stuff. All right, so don't be afraid to work with them. Okay, so let's talk about the future of personalized nutrition. Fiber requirements represent a microcosm of nutrition's evolution from population-based guidelines that, this is true for everybody. That's not the case. Toward individualized medicine. Metabolic context, genetic factors, and microbiome composition all influence optimal intake levels. Precision nutrition platforms increasingly incorporate continuous glucose monitoring, metabolomic profiling, and microbiome analysis to customize dietary recommendations. These tools consistently reveal substantial inter-individual variation in responses to identical interventions, i.e., that means that we all tend to operate differently depending on what we eat. We're all individuals. The one-size-fits-all approach to fiber intake will likely seem as outdated as universal calorie recommendations once personalized nutrition becomes mainstream. Biomarker-guided decision algorithms will replace arbitrary gram targets with context-specific protocols. Someone with optimal insulin sensitivity, normal bile acid feedback, and stable gut barrier function may require zero supplementation of fiber. Okay? Others with specific metabolic or digestive challenges may benefit from targeted interventions using particular fiber types at precise doses. The key insight: fiber serves as a tool rather than a requirement. Like any therapeutic intervention, it should be prescribed based on individual need rather than universal assumptions. This personalized approach respects both the complexity of human metabolism and the diversity of dietary patterns that can support optimal health. It moves nutrition science beyond population averages toward precision medicine model that characterizes other medical disciplines. Understanding fiber's optional nature, right, liberates individuals to focus on metabolic optimization through approaches that work for their unique physiology. For many people, that optimization occurs through carbohydrate restriction and ketosis rather than fiber supplementation. The science supports these individualized approach. The question isn't whether everyone needs fiber, but rather how to determine who benefits from which types at what doses. Okay? That determination requires moving beyond dietary dogma toward evidence-based personalization. Metabolic context matters more than universal guidelines. Okay? So it's all about how you respond, not how a million people respond. You are an individual. You should be treated as one. All right. Hey, thanks for watching, everybody. If you have any questions or comments, put them in the appropriate section. Also, this is a community. If we're here to answer your questions, if there's something you want me to cover in an upcoming video series, let me know. I'll start working on to get it into the schedule. So, talk to me through the comments or other channels. And as always, if you haven't done so, please like this video, subscribe to the channel, share it with a friend. You help the channel a great deal, so thank you for that, and you're helping a bunch of other people.